We're going to start now. Hello, everyone. On behalf of the SingHealth-Duke-NUS Global Health Institute, I'm delighted to welcome you to this webinar. As some of you may know, the Institute is focused on research, education policy, and capacity building initiatives in the region. And a complementary objective we have is to build a community of people interested and knowledgeable about global health. And our current situation more than illustrates the need for such solidarity in the face of health crises, not only in Singapore, but across the region and across the globe. So today's presentation is a continuation of our global health series, the goal of which is to engage the community in pertinent health topics across different domains. These are scheduled for every Friday every last Friday of the month at 2 p.m. And of course, initially we had them in person, and we had to took a couple of months gap in the current situation, but then we've now adapted to presenting that in a webinar series format as we will today. And we'll continue this as long as we are in the circuit breaker, so do look out for our next one. The advantage is that we can get more people to participate, of course, in this mode. So I'll now like to introduce our speaker of today, which is Dr. Logan Manikam, who will present his work with the Childhood Infection and Pollution Consortium, CHIP, of which he is the founder and director. Logan is a UK board certified public health physician with 10 years policy, academic, and clinical experience. His areas of expertise include infectious disease, antimicrobial resistance, child and global health, and he's also actively practicing. In addition to the CHIP consortium that he'll be talking about today, he leads the second phase of the NEON intervention, which is a multi-phase project that aims to optimize feeding care and dental hygiene practices in Southeast Asian children in East London. He moved to Singapore in June 2019, and where we had the good fortune to meet. And we met in rather interesting circumstances. We had communicated by email, and then he was coming in to meet, but I kind of pulled a fast one on him, and instead of just having a meeting with me, he presented him with a 3-person panel all ready to interview him for a job he hadn't applied. But he took it all in his stride. It ended up that the job wasn't quite the right fit, but we do look forward to working with him on global health issues in the region. I'm really excited to hear about his work today, and all of you will have an opportunity to ask him questions. You can put that in the chat format form in this group chat, and at the end of the presentation, he will answer those. So look forward to it, and Logan, over to you.
Thank you so much, Amina. Let me just share screen. Right, can everyone see my screen?
They can't talk.
Oh yes, that's fine. As long as you can see my screen, that's great.
Yeah.
Right. Hello everyone. Amina, thank you. Amina Marielle, thank you so much for the opportunity to present today. So Amina has graciously done a very good introduction of myself. So I'll keep my talk about myself brief and focus a lot more on the Childhood Infections and Pollution Consortium. So my name is Logan Manikam. I'm the Consortium founder and co-director. And what I want to talk to you today is sort of the work we've been doing over the past 2 years in 3 countries, so India, Indonesia, and Chile. I just wanted to highlight the picture in front here, and that's a picture of Jaipur's urban slums, which we've taken in some of our work late last year. I think many people asked that question in the first instance because CHIP includes animals. Is there any animals in an urban slum? And I hope the picture, really shows and highlights that there is livestock, there is companion animals in urban slums, and they play a part in the sort of picture of infections in the world. So let me just go on to my next slide. Hold on. Yes, okay, great. So my presentation outline, I'm gonna just talk briefly of my conflict of interest, define what's a slum, discuss CHIP's background and overview, our work to date in these 3 countries, so Jaipur in India, Jakarta, Indonesia, and Antofagasta in Chile, and then a brief talk on sort of the impact of COVID-19 on slums and whether stay at home is actually safe, and then the goals for CHIP over 5 and 10 years, and just a brief overview of some considerations if you're interested to do global health, and what are the challenges that you may be facing about that. So I currently have a financial or affiliation interest with four institutes. So UCL, I'm an NIHR Advanced Fellow. of which my main job there is to lead a trial to improve infant feeding practices in East London using the PLA community-based approach. I'm an honorary consultant in public health in the Public Health England Immunisations and Countermeasures Division. I lead and direct Assessor Global Health Consultants Limited, a micro consultancy that's based in London and Delhi, which really just consists of a five-man research team that sort of undertakes a range of paid consulting work, but also manages CHIP. And then lastly, I practice as an acute medical registrar in Medway Hospital, but that's sort of one every 8 or 10 weeks or so, every time I'm back in London. So I'm just going to briefly talk about what is a slum, because we recently had a workshop in Jakarta in February this year, and it actually wasn't in the agenda, but we spent a good 2 to 3 hours just talking what do we mean by slums. And I think when I first set out sort of setting up the CHIP Consortium, I kind of thought slums as, areas in low and middle income countries rather than a high income country. And it never crossed my mind of the issue of slums and informal settlements in high income countries. Now, this is a pictures courtesy of The Guardian. And of course, I'm sure many of you recognize that this is a pictures of our foreign worker dormitories in Singapore. Now, I won't sort of stoke controversy, but the reason why that sort of discussion came about in Jakarta is because a fair few of our colleagues, as part of the CHIP Consortium, are from Hong Kong, so from the Hong Kong University. And they actually argue that actually slums should consist of sort of across, irrespective of high or low income countries. And as long as they broadly fit the definition defined by UN Habitat, they should be considered. So just very briefly, the UN Habitat definition is individuals living under the same roof in an urban area who lack permanent durable housing, so sufficient living space, so not more than 3 people sharing the same room. And I believe that some of the dormitories here have a lot more than that. Easy access to safe water in sufficient amounts and affordable price, adequate sanitation, so public or private toilet shared by a reasonable number, and security of tenure that prevents forced evictions. And that sort of guides the sort of CHIP Consortium all the way through. Now, CHIP's background, so it initially started off in about 2017 when we were awarded in a Medical Research Council, a UK funder, funded a nutrition study in Rajasthan's rural villages. And the focus was to develop integrated health, education, engineering, and environment interventions to improve malnutrition in rural villages. So completely different focus, so malnutrition in a rural setting. And CHIP, I took that and sort of refocused that to tackle infection in Jaipur. Now, Jaipur is the capital city of Rajasthan, and that was done for pragmatic reasons. Very much that you need to have very good, solid, stable partners in the local context to be able to do this very complicated research. And I also incorporated One Health. I spent about 1.5 years in Chatham House doing global health policy work. And there I was exposed to the concept of One Health and how that really meant in sort of the world that we are facing today, as well as technology-enabled citizen science, which I'll explain later. So I obtained about 40,000 or so funding from UCL and Hong Kong University to really do 2 workshops in Jaipur and Hong Kong and do a bit of work in Jaipur as well. I then involved my consulting firm to sort of maximize CHIP's success. So I expanded it to 3 countries, so in 3 regions. And I think the key thing here is that one of the key early decisions that I made was to develop as a consortium rather than a board or a supporting group, so to speak. And I think the key thing is that really the problem is just very complex. It's too difficult for any one person to own and lead. And I need the support of everyone else to sort of support me to actually achieve this aim. And the other thing was really to have a maximum impact across multiple countries. In that sense, because CHIP is collectively owned, anyone can join, anyone can apply for funding, and anyone can sort of lead on programs and support the work in any country they choose, as long as they adhere to sort of our member rules and sort of our policy. Now, an overview. So the overarching aim, and it's a very long aim, and I'll try to break this down over the next couple of slides, is to reduce the infection and antimicrobial resistance burden in children under 5 in slums globally through identifying and addressing One Health infection factors using co-produced behavior change and slum upgrading interventions using technology-enabled citizen science. So it's very long, but I will break this down. Now, I think what I show you on the right is essentially a snapshot of how things would look like over 4 years. So what do we actually plan to do over 4 years? And I think the absolute basic is you start off first with the study setup phase. So you basically do some feasibility work, like what we have done so far in the past in the 3 countries, where you basically get their views and establish whether they think infections are a problem and what are the key factors. And then you do very comprehensive formative research. And the formative research is key because The thing is, if you're not absolutely sure where the intervention targets are, then you're not sure that the things you then make to address it actually improves it. And I think the key thing to say is that CHIP was born because actually there is a lot of work on water, sanitation, and hygiene. You know, good, safe water, clean hand hygiene is really important, and nutrition is important. But the two together still don't account or sort out all the infections. So there are other things going around. And I think that's the key thing here, that you need to be really meticulous in looking at your formative research to make sure the next things, which is making the interventions with the community and then testing it and sort of scaling it out, actually works. And that's sort of the overarching aim and the key research program that we propose to do over the next 4 years. Now, I'm just going to explain the two key things I mentioned. So One Health and citizen science. So One Health is on the left. And One Health is essentially a globally recognized concept now. If you Google it, it's discussed in the World Economic Forum, in Chatham House, and the Rockefeller Foundation, really big players who are both in health and non-health. And they, it ultimately just aspires to understand and says that actually infections are a function of human, animal, and environmental health. So it's not just any one, you need to consider all those factors. Now, citizen science is a bit more nuanced. And citizen science, many would probably recognize it as something similar to participatory research. But the idea takes it a bit further, and essentially is the idea of you enabling the local communities, those who are literate as well as illiterate, to actually use mobile phone applications to capture the surroundings around them. So the idea is you can use, or you give them applications by which they can record infections or record the surroundings around them that actually causes infections. And that is then given information for us to then action and actually try to address that. And that's sort of the sort of two overarching aims. And whilst we have a broad focus of tackling infections and AMR, to be honest, the reality is that our targets cross a range of things way beyond just infections and AMR, which links back to the Sustainable Development Goals. Now, I just very briefly will talk about the consortium. So this is a picture from February this year, so it's not quite up to date. We have a few more partners now since then. But in a nutshell, in the UK, we have sort of my consulting firm, Assessor Global Health Consultants Limited, and my team there, UCL. So Monica Lakampol is my co-director, and then a range of UCL academics. In Indonesia, we have the Indonesia One Health University Network, as well as the Human Initiative. In India, we have Save the Children India. We have Cohort, which is essentially a One Health regional network. Rajuvas, a academic university, a few independent consultants, JAS, a local charity, and then JNU, another academic division. In Japan, we have St. Luke's International University, Tokyo. In Thailand, we have UNPF. In USA, we have Columbia and Georgetown. In Hong Kong, we obviously have the Hong Kong University team, a very big team. So I come back to where we first started. So we started in May 2019 in Jaipur. So we had a first consortium workshop where we organized laboratory visits, slum visits, and a lot of that aspect was trying to introduce everyone to the concept of the consortium. What are we aiming to achieve over the next 5 to 10 years? And whether people were still interested. I think that's the key thing, because not everyone will be interested, once you listen to it. And I think the key thing is to give everyone the opportunity to say, yes, I'm really interested to stick around, or no, actually, I'll happily join later, or it's not my interest. And that was the first key milestone for us. And that sort of led to sort of the work that we then ultimately did over the 3 countries, which I'll sort of go through the next few slides. So I think the key questions, the thing is that you can't just run in and do a big program in a new country or in a new slum without ever actually, at the very least, just talking to people. So talking to the slum dwellers, asking them, is this what they want? Do they care about this? Is it easy to do this work? And does it actually matter to them? I think that's the key aspect here. So before sort of applying for $1 million funds and say, yes, you want to save the world, we actually sort of did some field work. We basically had a small team of 5 or 6 academics and NGOs sort of coming together in those 3 countries and doing sort of 2 or 3 field trips together with local partners to really try to identify this, sort of answer this 4 questions. So the first question, so what's the One Health infection pathways relevant to children under 5? And then the second question, what's the social geography or community structure of the slums? The third question was quite important. So formative research, which is what I alluded to, requires a lot of sampling. So your nose, throat, stool, hair, milk, water sampling. And is it actually acceptable to take all their samples in children under 5 and their families to identify where these infections are coming from? And the last bit is the the feasibility of using OpenStreetMap or the technology in the slum. So can you actually get mobile phone coverage? Can you actually map this out in a geotagged action camera? So this is some of the things we sort of did in the late last year, between September and December last year. So the methods of what we did, I broke it down to sort of 5 key topics. The first was the criteria for site selection. So why these 3 countries? Who are local partners? The second is a training session for the champions, our local partners there. Third is the transact walks, social mapping, then interviews under 5 parents and community champions. So I think the first thing is India. So India, it's big, 1.3 billion people. The under 5 mortality rate of 40 per 1,000 lives. Now to give you contrast, Singapore's under 5 mortality is 3, and the infant mortality is 2. So obviously very big difference. And just to give you some figures on the right, so the proportion of children who actually had pneumonia, who were taken to a health provider, is only 73%. And the children who actually had diarrhea, only 20% received salt. So this is really poor figures, in contrast to what you can expect in a country like Singapore. Now, partners in that country for the operational was Save the Children in India, so a very big national charity, international charity, and JAS, a local charity, only based in Jaipur, but had lots of local links in the Jaipur's urban slums. And you need that. You need the trust of this local community to be able to do this kind of work. Indonesia, 21 per 1,000, so not that much better, to be perfectly honest. Very big population, 250 million or so, our local neighbor. And again, in terms of statistics, not that much better in terms of how they actually access healthcare. Only 40% of children actually receive salt, so not that great. And our key partners was Indohan, which is basically the Indonesia One Health University Network, a very big network that sort of does academic research, but also operational programs, as well as Human Initiative, the largest sort of charity in Indonesia. So big partners there. And lastly is Chile. And I guess people always ask the question, why Chile? So first of all, we had links in Chile. So that's the first thing. You need to have good links. But second of all, for many of you don't know, Chile is the only is our high income country. It's actually essentially a high income country. So come back to that point I mentioned about, there's slums everywhere. It's not just a low and middle income country problem. We wanted to see and really contrast, how does slums look like in a high income country relative to sort of low middle income countries? And of course, as you can see, the statistics are much better, but still nowhere near in comparison to Singapore. But in essence, slums still exist, and we wanted to see how it sort of looked like. And our partners were an academic institution and a local government, so the municipality of Antofagasta. And you may ask actually why Antofagasta rather than sort of the capital, and that's really because Antofagasta is the north of Chile, and therefore actually is taking the brunt of a lot of the migrants from Venezuela. As I'm sure you noticed, sort of the human crisis there. So definitely an area we want to sort of capture. So training session, I think that's really important because again, you can't just rush into this. So here's our team, and I want to describe how sort of multidisciplinary our team is, just to give you an idea of where everyone comes from. So on the center there, the Indian chappie there, he's Hemant Chaturvedi. He is an assessor employee. He's based in India. We actually poached him from Save the Children in India. So, they're not too happy about that. And he has years of working in communities, not just in Rajasthan, but actually in sort of other parts of India, where they actually run programs. So, how do you actually get people to actually take supplements? How do you get people to sort of use water, sanitation, and hygiene facilities? And he had tons of experience for that. And we hired him for that basis. And he works for us full-time based in India. On the right is Yasmin Bukharim, and she is a senior research fellow in Assessor, sort of my lead operational program lead for CHIP. And she has a background in data management, so sort of very good for this sort of stuff. On the left is an Indonesia One Health University Network employee, so the sort of the main academic link. And then the guy here on the far left, he's Hector Altamirano. He's an architect from UCL. So just to give you some context, you're trying to bring as many disciplines together to sort of really train the community champions, but actually do all the work. Because to be totally honest, there are many things that me with a health background would completely missed that an architect would pick up and vice versa. So I think that's the key point here, is to try to bring it as interdisciplinary as possible to identify all the factors as you can. So Transect walk. So for those of you who don't know, transect walks is basically a systematic walk across a defined path, which you call sort of a transect, in the community, so you can identify all these factors. And it's not just for infections, it's a methodology you can use for anything else, like gender-based violence, for security, for nutrition. It's sort of a methodology you can apply anywhere to identify what you want. And it's always done in collaboration with your champions as well as your sort of local partners. So I'm going to show the results of that. And I chose to show the results by pictures because I thought that's the best way to show that. So these are some of the pictures from Jaipur, urban slums. And what you can see, obviously, there's huge amounts of pollution, waste everywhere, but also actually livestock. So goats sort of far corner at the bottom. And on the top middle, sort of pictures of how the cooking facilities are. So obviously very compressed and very dense in relation to what we're normally used to. More pictures from Jaipur, again, cooking facilities in the bottom. More livestock, sort of chicken on the right, and then the bottom right middle is sort of what one of the communal toilets. So not very great in terms of how you look at some of the facilities available. And Jakarta wasn't that much better, to be honest. And to be honest, I actually thought it was actually worse. So what you see here in Jakarta is a slum where the local population sort of live, and you can see the picture on the right, where they actually live in the slums. And the reason why they live essentially near a dump site is because they then can recycle or pick out things they can then sell on, and that's how they make a living. And you can smell essentially the pollution in the air. You literally can smell it, and it puts the Singapore's haze to shame, and more than anything else. And everyone sort of were wearing FFP3 masks than anything else. And on the top right, top left, you can see a picture of the cooking facilities together with where they store their clothes. Top left, really just to give you an idea, that's the size of a house. Essentially, that you literally open the door, and that's a family living there. And then they'll use a shared communal facilities for sort of cooking and cleaning, what you see in the bottom left for everybody. So everyone keeps their stuff together. And that's sort of how they live. And the right picture on the right sort of gives you an indication of that. And Antofagasta is interesting because, it is much more developed. So you can see this starts to be a distinct difference in terms of some of the housing characteristics. You can see it's much more built up, much more able to weather durability. But still, actually, there's still elements of slums within that. So, there's still infection risk. There's still sort of other key factors here. It's just not as bad as the other two slums we have seen, other two countries we have seen. And of course, I make a point that even within the country, there's lots of differences. But of course, you can only pick it up through sort of local work, comprehensive work. Now, I'll give you an idea of how a transect walk looks like afterwards. So what we do is after we actually do the transect walk with the community champions, we actually draw it out. So we draw out on sort of the same day what we found, what are the key pictures, what are the key sort of characteristics we identified within that. So this is for Jaipur, and you can see sort of, from a transport point, we map out how the entire duration or the way we walk through, and then all the key factors to sort of influence the infections that we thought were sort of relevant to that. I'll briefly talk about this because it's still a work in progress, but come back to the point about the technology. So the idea is that for Indonesia, this is a picture of Indonesia, is that you can actually try to map out using a geotagged video camera, or in our case, a geotagged mobile phone, all these different factors. So we overlay that onto an open street map. And what we do is we then set up, so the slum dwellers themselves, they can then use their own mobile phones to report infections, but also add to this map. And the idea is very simple. So if you can get your slum dwellers to identify those infection points, you then give them the opportunity, the ownership to try to address it as well. So, you need to give them the solutions as much as possible. And that's where the citizen science comes to life, because at the end of the day, we can't run a program indefinitely in a country. It's not physically possible. And especially with COVID, as you sure you realize, those things sort of get interrupted immediately. And the idea is to build some sustainability within the programs using citizen science and technology where possible. So it's sort of watch this space, so to speak. Social mapping is very much focused on sort of drawing out the local slums. So in many of the slums, in some of them, there are maps, but in many of them, it's actually impossible to identify who lives where and what sort of houses and characteristics are within there. So, and even in sort of what you can see in the bottom right is a picture of CHILE, the same methodology applies everywhere. It's just that in some places they use chalk, in some others they actually use A4 paper and draw it all out. And how it works out in practice, using sort of these fancy diagrams is this. So this is in Chile. In Chile, we were fortunate because the municipality actually have, or the government actually has maps of slums, because they consider slums to be a problem, but they also consider it to be a problem they want to solve. So one of the ideas is they define these maps to help the local populations. And what we do on the right is, we don't see this map beforehand. Well, the local slum dwellers don't see this map beforehand. So they draw this out themselves, and then we try to compare that to what the local government gives. Now, the key thing is that for Jaipur, there wasn't any map. So literally what they drew was the only thing we had. So you can see how important that is to sort of do the future work they want to do. And then what you can see here is sort of the highlights with the families who are with children under 5, sort of our, the real people we were trying to target and influence. And then the last bit was the interviews. I won't dwell too much on the interviews because there's a lot of key, as I'm sure from the pictures you can see, there's huge numbers of One Health factors to sort of address. But one of the key things we wanted to look at is sort of come back to the sampling thing. So, the idea is that, in a nutshell, if a child has what we want to do in the formative research, if a child has an infection or if a child has a fever, just say fever and a cough, what we want to do is have a field team go in and actually sample that child nose and throat together with the animals, the caregivers, and everybody else to see where this infection came from. That's basically in a nutshell, sort of some of the complex formative work we want to do. In order to do that, you obviously need to be able to take samples. And of course, the key thing was we wanted to see whether it really was acceptable. So stool samples, nose, throat, hair, air quality, so this is really a key factor here, water quality, milk, lava, for vector-borne diseases like malaria, blood, and urine. And I think it was surprising, but actually nearly all pretty much said they were very happy with most of the samples. And however, there were some concerns about the safety of equipment for air quality, especially because we would leave it in public spaces and whether it might be stolen. So that was, I guess, the only major concern there. So I come back to this diagram because, I'm going to give you sort of, this is, great in theory, but how does it actually work in practice? I've shown you some really great pictures, I've shown you some diagram, but what does it actually mean, in reality? So what we did was using all these findings, and before our second workshop in Jakarta, we sat down as a team, so the assessor team, my co-director and myself, and tried to draw out a One Health map of all this, how these factors influence infection. And this would then set the scene for our next stage of work sort of later on this year. And so this is it in reality, sort of a mess, essentially, of factors. And the idea is, and I'm not asking you to sort of look through this in sort of in any form of detail, but the idea is that it's really complicated. And that's why it hasn't been cracked, the infection and AMR problem hasn't been solved. Is that there's a range of factors in human, animal, and environmental health that sort of influence infections. The other key thing is come back to that sustainable development goals I mentioned. And you can see in the top right corner, that's what I mean. It's not just about infection. There's a range of SDGs that you need to consider or actually influences beyond what it is. Of course, this is what we made. And of course, what we then needed to do was actually to take it to the consortia of sort of 30 members and ask them their views based on what they thought of our findings. So that led to our second consortium workshop in Jakarta in February this year. And again, you can see social mapping in action here from the diagram sort of highlighted here. And we had a few more partners since then. And this is the sort of a one-pager of what happened in the consortium workshop. So on the top left, obviously a picture of everybody, but actually it's really important that it's not just a workshop, a 5-day workshop where you just discuss findings in a hotel room. So we brought everyone to the slums, and again, the same thing happened in Jaipur on the top right corner. So everyone saw that in action. On the bottom left, everyone did laboratory visits. So because the key thing is that you need to be very happy. This is really complex work, and you need to be happy that the laboratories in Indonesia and in Jaipur and in Chile are up to scratch to what you want to do, because it's not feasible to take 10,000 samples and then send it to Hong Kong University to process. So everyone needs to be happy here as to how can you do it. And then of course we looked at the diagram again. So everyone saw what we found. I did the same presentation, and then we said, look, what do you guys think of our views of this diagram? And that obviously turned the entire diagram around, and that led to this, sort of a much more refined conceptual diagram, which we've just published in One Health. And it sort of, as you can see, it starts to highlight the human, animal, and environmental factors that influence infections and antimicrobial resistance. What you can see in the bottom right is that actually there's more SDGs now. We've actually added a few more that we didn't think about. And of course, what we plan to do, this is sort of a roadmap of what we hope to focus over the next couple of years, but actually the diagram will keep changing. As we find more things, we do more literature searches and actually do more of the research, what we want to do is to keep adding to this, because especially as we expand in industry countries, but also expand to other countries, we will find more things, and we want to add to this, and sort of, so watch this space, so to speak. So our next steps for 2020. So from the company side, what we're going to do is a panel study in Jakarta, and a panel study is what I described, a very comprehensive sampling study. It will also include SARS-CoV carriage in children under 5 in urban slums in Jakarta. So we'll do sort of 20 to 30 families to see how we can link all the samples together. Data management is really important. How do you bring all the data between these 3 countries into the States, Hong Kong, UK, and Japan, and safely and securely, because data security is a big deal. And we're building a data warehouse. We are applying for some funds to develop a mobile app in Jakarta. And we're in the moment currently considering to do a post-COVID-19 impact study in Czech slums. We have a 3rd CHIP workshop in Hong Kong planned. So we actually push things around. So actually we did a Jakarta workshop instead of a Hong Kong workshop, because we want to see Jakarta. And then a few of the consortium members are doing a few other projects. So one is doing the same S1 feasibility study in Sierra Leone, but a focus on maternal and child health as well. So looking at pregnant moms, because they've said as a priority, and also a global virtual conference after that, so showcasing findings. And then a few other bids in Indonesia, India, Chile, Peru, and Ecuador. So again, I come back to that point, that if this was just a technical advisory board and just my project, I wouldn't be able to do all this myself. And the idea is that it's not just one person's sort of pet project. It's trying to make a sense of collective ownership so we can all address the problem together. And we have another colleague in Colombia who's basically taking an India fellowship to do a pilot sampling study there as well later this year, once COVID-19 travel restrictions are over. So I've been asked to do a bit on COVID-19 and slums. So I have 2 slides, and one was created from our WASH colleague, another from our built environment colleague. So this, I've shown you lots and lots of pictures, and I think it's sort of pretty apparent how COVID-19 can sort of really influence life in urban slums and how this actually impact on a slum dweller. What you can see here is sort of the WASH angle, the water, sanitation, hygiene angle. And what you can see here, this is from the Jaipur urban slums. We actually drew out sort of the possible routes to get to the water collection points and the community toilets. And there are various choke points where there's literally so insufficient space to walk through that is overcrowding, and people definitely not being able to meet the 2-meter social distancing rules. And it's just not possible. You just can't meet that rules at all in this sort of urban slums. And you can see how this sort of layout and setup actually perpetuates COVID-19 transmission. The other is the built environment. So again, you come back to the point that, why do I have veterinarians, built environment, WASH experts, engineers, geologists in the consortium? Is because I just don't see things that they would identify. So this is a Jakarta urban slum picture. This is a picture of a single house, a 3x4 house, just like how I've shown the pictures before. And as you can see, there are many risk factors for other things. So, there's a corrugated roof containing asbestos, thermally uncomfortable, fully constructed house of poor air tightness, a single room house, no water, houses in close proximity, dampness, open drains, and with wastewater. So all of it leads to sort of very unsafe and crowded environments for you to stay at home. Definitely not a safe place for you to stay at home to avoid COVID-19 transmission. But unfortunately, as we have seen in many of these countries, is that once these lockdowns are imposed, they have no choice. They end up having to come to these homes and stay there. So what that leads is of course, more COVID-19, but also more other risk factors for other infections and other diseases. So definitely a very hostile environment. So CHIP's 5-year goal. So just very briefly in goals. So where do I see us in sort of 5 to 10 years? I think the first thing is that there are lots of bids and grants being applied for to sort of expand CHIP across all these countries. And I think that's really great from a project perspective, but what you want to do is to bring it all together. So, and I would say that, say in 3 to 5 years, we would know which countries that we will be stable working in big programs. And then what we'll then do is to apply for research grant funding or strategic funding to bring all of this out together, sort of a continuous funding to keep CHIP going. So what you can see is examples of very similar type of consortiums looking at infections and slums that have garnered quite a lot of funding. But that's not the end of the road, essentially, because this is really research funding. So this really just what it does is just to identify what the targets are and create interventions. It doesn't really scale up things. So that's sort of the next stage of the work. And sort of it comes to what I come back to, the research impact. So, and research impact is sort of the effect research has beyond academia. So I have to be totally honest with you. I did not create, was I initially created CHIP with the idea of actually getting a job, actually what I found that actually it became more of a calling or a passion. And the idea was that I didn't just want to get papers. It wasn't about that anymore, because I have a job, essentially running a trial already in East London. But the idea was actually trying to make a difference to all these Londoners who are having the most terrible times with COVID-19, and even in the best of circumstances, and how do you actually make a difference there? And the definition of research impact is when the knowledge generated by our research actually contributes to benefits influence society, culture, our environment, and economy. And I give you a term that it's known that it takes about 17 years on average to get from research, so that paper that we publish, into actual full practice. And only 50% of healthcare interventions ever get adopted, and it's even less for public health and behavior change intervention. So that's sort of what we do in public health. So there's definitely a need to sort of expand and sort of make the difference. And I come back to a very good slide by Dr. Zhao, degrees of impact. So as academics, most academics will be happy with just spreading the message. And the thing at the very bottom, you get a great journal article in the Lancet, you get some press release saying you've done some great job, hoorah. But then what then happens is that actually there's sequentially other things that you need to do, which is a lot of work and may not be in your priority area to sort of do and sort of lead on that. And that is the thing that actually is going to make the change and make the difference in the slum dwellers. So it's not just doing a paper and saying, oh, I've done some really good research. It's actually covering all the entire spectrum. And the idea was therefore creating the consortium, so again, highlighting the Development Action Group Task Force that consists of NGOs, academics, policymakers, international charities, local charities, actually allows you that even if it is not your priority as an academic, it is someone else's priority to get it all the way through. And I think that's the key idea here, is to bring it all the way from creating the research, or creating the findings, to actually scaling it up across these countries to make a difference. And this is a really complicated diagram, but essentially is our pathways to impact diagram, as to how we actually intend to get it over the next 5 to 10 years. But what I want to highlight really is in this entire complicated diagram is this capacity strengthening, so the third column, and the very bottom there, which is raising awareness of the importance of childhood infections. I think the key thing is that in many academics or in hospital settings, we don't tend to think about the public or the wider public as to what they do or what we want them to think they do. So what I try to do, even in the early work that we did in our feasibility study over 3 months, between September and December, is to run a social media campaign, just highlighting the work we're doing in these 3 countries. And we had about 1 million reached, 33,000 likes, comments, or shares. And it was funny because we didn't specifically target Indonesia, even though we tagged Indonesia as one of the sort of tags on social media, but about 40% of those likes was sort of from Indonesia. So it shows that people are interested. And they're very keen to get involved. And I think the thing is, you just need to invest in comms and social media. You can't just live in a bubble. Otherwise, I think the labor changes. So the 10-year goal. So I think the key things to say that, you can't substitute for policymaker advocacy. And when I mean policymaker advocacy is local and national governments, international charities, to actually try to make a difference. But I think COVID-19 has definitely shown that there's really no money for slums. I mean, there have been a few good projects to try to alleviate the COVID-19 impact, but in many circumstances, there's nothing really being done. It's sort of every man for himself, and those in sort of the lowest social class groups being sort of the worst affected. And what we're trying to do alongside sort of the policymaker work is sort of engage private sector. And it's actually exactly example from Singapore. So in Singapore, DBS Bank actually partnered with IIX to set up sort of gender-based interventions to target sort of Pakistan, India, and Vietnam, correct me if I'm wrong, household-based microfinance loans. So you give the loans to women to actually set up their own businesses, but in doing so, you also improve a range of health and social care outcomes. And the idea for us is to do the same thing, but looking really at the slum upgrading. So if we give people money to improve their houses, so raise the mud floors, improve the housing environment, does that make a difference? And this are some of the things we're looking to explore in Consortium over the next couple of years. And I think, yes, so our last slide. So I think many of you may look and say, wow, this is really interesting. How do I get involved? And I think it's really good. And even, to be honest, I really came into global health quite late in the game. So in 2017. So for most of my career, I was very focused on UK health rather than global health. And there are a lot of things they don't tell you about, which I hope in one slide sort of tries to elucidate. So first of all, it's the idea of working together. it's already very difficult to work together in teams with different healthcare professionals. But just think, across different countries, the global north and the south, there's different cultures, organizations, perspectives. And the key thing is that even though, people might seem crass, everyone is entitled to opinion. You need to be definitely consider language use, because there's a whole range of different, professionals here. I mean, we have architects and veterinarians in the same room talking about infections, right? And I think the key thing is everyone needs to be respectful and polite, both in person and email. And the key, therefore, thing is to enforce it. So every time there's an argument or disagreement, I or my co-director usually ends up sort of getting involved and say, no, you need to let that person have their view. And so everyone has a very neutral and safe space to discuss that. The other thing is having equitable partnerships in terms of money, in terms of publications and recognition. So it's already very difficult in any country or any situation to sort of work in teams. But consider that in the consortium alone, we have multiple different partnerships. We have low-income country versus high-income country. We have senior professors versus junior students, pre-docs and postdocs. And we have small versus big charities. Already there's some dynamics there. And even within the country, within NGOs, so Save the Children versus Academia Public Health Foundation India. And therefore, we have an exec committee that scrutinizes every grant, project, and publication. So I think those are really important things. And I think that's it. Thank you very much for listening. Please do sort of follow our Facebook, Instagram, Twitter, and LinkedIn pages. If you want to find out more about our work, please go to our website, where you can see the minutes from our most recent consortium workshop in Jakarta. It's a very nice brochure. Alternatively, please just drop me an email if you want to find out more. That's it from me. Thank you.
Great, Logan. Thanks so much. That was really a lot of information to absorb. So I hope people really were able to absorb it. And maybe as people have some questions, you can type it into the chat box. But maybe I can kick off by asking a question while others are thinking about it and writing it up. So, you referred to it a couple of slides back, I think, on, the impact of COVID-19 and how it's shown that it's been a little bit of everyone for themselves. And, we really have to work in this space to be more cohesive. So, in your experience with these particular projects, have there been opportunities or actual, activities where you've been able to maybe link in with district level, state level, even central level government initiatives? Because I'm sure every government, is concerned with it and doing something or the other, although each one is tackling it pretty differently. But in your personal experience through this consortium partners across the few different countries you're involved in, have there been any active involvements and interactions and support actually?
Yeah, so come back to, I forgot to mention that in some of the activities we're doing right now is that we've just sort of submitted 2 commentaries on COVID-19 using these diagrams. And as part of that work that we wanted to find out what the slum dwellers were experiencing, we actually asked our local partners, so in our case was JAS, Human Initiative, and the Municipality of Chile, and asked them, well, actually, being the sort of the end user, or the not end user, but the end organization that supports this local slum dwellers, what's actually happening on the ground from the local level governments. So we actually established what different government programs were available to this, to support the slum dwellers. We found that Jaipur, there wasn't really much at all in our experiences. And I think, to be fair, I think it's come out in the news quite a lot about the fact that it's a massive lockdown. But in contrast, in Indonesia and in Chile, there has been quite a lot of support in terms of sort of provisioning of food and trying to set up temporary water, sanitation, and hygiene facilities. But having said that, it is a snapshot, because obviously, Jaipur isn't the whole of India, so we don't want to overgeneralize. But having said that, even from JAS, despite not having necessarily that much of state-level government support, there's been a huge uptick in donations to support them. So they've actually been running a huge amount of programs, I think 10-fold increase in size in terms of some of the social charity programs, in terms of food provision, because of COVID-19. So, they've had sort of a lot more resources themselves to run big programs, and that's sort of a main sort of feature for that. Yes, that's kind of really my view on that.
Great, thanks. So I don't know if anyone in the audience has any questions or.
It's good.
Yeah. so overwhelmed with all the information to absorb that it's.
Yeah, apologies. There is a lot, but if you are interested, just do have a look at the website and our social media pages. There's not
Yeah.
many more. We are obviously very keen for people getting involved. Just drop us a line.
Yeah, so maybe while again, as others are kind of formulating the questions, that was an interesting thing you mentioned right towards the end. What was it? Was it a social impact bond or whatever the DBS created with the?
Yeah, I think I should maybe I want to reshare that.
Yeah, that. So
it's
do you?
I have to be. It's not my creation at all.
Yeah.
Actually, if you Google it, essentially, it's a lady from the iExchange who set this up, who basically found that it's very hard to generate interest in governments when there's multiple competing interests in terms of actually running out big scale programs. So the idea was that you actually create a product that the financial sector could pick up in terms of social impact, but that would give a social impact as well as a return on investment. And if you Google it, you can find the actual product. So what they did was essentially set up an $8 million US bond, then gives itself a microfinance loan to about 300,000 families, where it's a loan. So you actually have to sign up at an individual level, a loan to set up a business, and that would then the loan then creates the opportunity to set up a business. They then return the investment by sort of paying interest on that. But the microfinance loan is much more competitive interest rates because we know that most microfinance loans are much more high interest rates and therefore very prohibitive. But in this setup, they manage to sort of get much more lower rates than commercially available. And then at the same time, alongside that, within a sort of the logic model, you actually show that alongside the financial return, there's also improvements in gender-based outcomes. The fact that you're actually empowering women to give them opportunities to sort of create wealth and sort of improve their own lives and health. So it has both a financial and non-financial gain to individuals or in households. And it was so successful, the first 8 million bond, that they end up then setting up this next one, $100 million US. So much more bigger. Okay. And I think the key thing to say though, that it is household level. So it can't replicate government level programs like social media behavior change. You can't, it's very much more harder to run a community level programs on that, but it's still another sort of a string to your bow, so to speak, to, to give some ways to scale up. And this is what we want to do in CHIP once we have, sort of a marketable product at the end of that.
Yeah, I think great opportunities to kind of branch out in a slightly different direction.
Yeah.
So, and then for you personally, this continues to be your main baby?
It's my baby, yes. It's not my actual job. It doesn't pay me anything. To be honest, I'm investing my own money into this. But it's the sort of thing that, COVID-19 obviously has a dramatic impact of all of this. But, you just look out in yourself and you just think, there are people out there in the world who are really suffering. And if there's something that we can do collectively to help improve their lives, then it's great. Like I said, when I first started this, I didn't have that vision or didn't even have that belief. But it was actually having all these partners who were giving their time for free, all joining in the Jakarta workshop. A heck of a lot of people attended. And they said, we're very happy to support you with all the staff time you need. This is a really good idea. It gives you the traction thing. Oh, actually, it's not a completely half-baked idea. Let's keep on going and try to build on this. And we've started to get some results, slow and steadily. So I think watch the space. It'd be hard to say how it look like in a couple of years, to be honest.
Absolutely, we'll be watching it closely. And then maybe the other very nice graphic you had was, that impact scale, so where you maybe you can go back to that where Victor Zhao, I thought this is, for anyone interested in global health, it's perfectly kind of, it's all what speaks to you personally, right? So it's perfectly fine if you, at whatever stage of that you are. It's not that everyone has to be, all along the way. So I think, for people who are interested in global health, they can be thinking of where do I fit into it, and where am I comfortable, where are my skills the most appropriately utilized, so where do we have the comparative advantage, and but think about these things and think about that whole spectrum of impact. I thought that was a really nice thing, which is obviously across for any kind of project, whether it is community based, whether it's a clinic based, whether it's hospital based, all these kind of things are relevant. So again, to encourage people, who are kind of watching, that these are the many different ways you can engage.
Yeah, so I think I certainly hope to not deter anyone, but I think the key idea is that there's only one, you're only one person in the scheme of things, and you can't do everything. And I think even if you are doing a small scale project, whatever it may be, there are always other people who may be interested in your work, who is willing to take up the burden of something else. But then at the same time, there's so many ways by which you can get involved in any aspect of impact. And of course, it's not just global health impact, it's also Singapore health impact. But any project, anything else, there's always different ways you get involved. So even if you're not an academic, you can be really involved in policy change. The breadth is just there. But it's very nicely captured in this slide. Although focused on an American setting, that's why the American lingo in that.
Yeah. So I don't know if people don't have any questions. I don't see in the chat. If anyone really doesn't want to write it, they can unmute themselves, I guess, and ask a question.
Or email me. I'm always happy to any questions.
Yeah, you can always follow up with Logan by email. If not, we can kind of just say thank you very much for taking this time to be with us. And, I think, this format is certainly something to be utilized, not only now, but in the future. And that way we can make sure that we stay connected with a lot of people. I do urge everyone to look out for our next webinar kind of notice, which will be, like I said, especially we're having a webinar series on different topics actually throughout. And you'll be if you're on our mailing list, you'll be getting that. But then certainly we are continuing with our Global Health Seminar series, which is the last Friday of every month at 2 p.m. So we are going to continue with that and hope to see all of you, and hope you kind of learn something from this, and stay well. And that's it from us. I think. And Logan, thank you again. And, hopefully we'll be in touch by email for sure. And hopefully at some point we'll be able to meet again.
Sure. Some point.
Yeah.
Thanks very much. Stay safe.